Ever just, stop and think about how you solve problems. Like your computer freezes, you figure it out, or you look outside, see clouds, grab an umbrella. Simple critical thinking, right?
Right? We do it all the time without really labeling it.
But imagine shifting gears entirely. What if the problem isn't a glitchy laptop, but someone's health, their actual life? The stakes are just fundamentally different in nursing.
Completely different. The complexity skyrockets.
Welcome to the Deep Dive. Today we're getting into the real nuts and bolts of critical thinking and clinical judgment core skills for any nurse.
Absolutely
For
essential.
using Fundamentals of Nursing is the 11th edition by Potter, Perry, Stockert, and Hall as our guide. It's foundational stuff.
A classic text for a reason. It lays it all out.
And our mission here is pretty straightforward, to give you, especially if you're a nursing student, a real shortcut to understanding how nurses make those critical decisions. The ones that ensure patient safety and the best possible outcomes.
We want to bridge that gap between the textbook and the bedside.
Exactly. We'll break down the jargon, talk through procedures conceptually so you can picture them, and tie it all back to what you need for the NCLEX and just good practice. Whether you're aiming for hospital work, community nursing, home care, wherever.
Hopefully you'll have some of those aha moments.
That's the goal, those moments where it just clicks. So let's start with the basics. What really is the difference between just doing tasks and being a professional nurse?
That's a great starting point. It's really about the thinking behind the action. It's not just about, say, giving a medication. It's about observing subtle changes in the patient, pulling together different pieces of information, maybe lab results, what the patient says, what you see, recognizing what the actual problem is, figuring out the best plan, and then acting on it, often quickly.
So it's that whole analytical layer on top of the skills.
Precisely. That's where critical thinking and clinical judgment come in. Formally speaking, critical thinking is the ability to think systematically, logically. You need to be open to questioning things, including your own reasoning.
Self-reflection built in.
Yes. The aim is always to focus on what's important for the patient and get those desired outcomes. In clinical judgment, the NCSBN calls it the observed outcome of critical thinking and decision-making.
Okay, so it's what you can see as a result of the thinking.
Right. Or, another way to put it, it's the conclusion you reach about a patient's needs or health problems. And that conclusion leads you to take action, maybe avoid an action, or even tweak a standard approach based on how the patient is responding. It's this dynamic mix of knowledge, experience, and that critical thinking process.
It really separates the RN role, doesn't it, making those judgments?
It absolutely does. It's why RNs are responsible for seeing those changes, analyzing data, recognizing problems, planning, and acting.
The textbook mentions a model for clinical judgment, not like a rigid flowchart, but more conceptual.
Exactly. Think of it as a way to understand all the moving parts of nursing practice. You've got patient needs at the core. That drives your critical thinking, which then informs your clinical judgment, and that leads to your clinical decisions. It's a cycle, really.
A continuous flow. Makes sense.
And within that critical thinking competence piece, there are key elements. Your knowledge base, obviously. Your experience, huge factor. The environment you're working in. Your own attitude as a thinker. And, of course, professional standards.
So all those things feed into how you think in the moment.
Right. Let's take an example. Patient with pneumonia. Your critical thinking immediately taps into knowledge about breathing, oxygen levels. You're listening to their lungs, thinking about suctioning, maybe anticipating anxiety because they're short of breath.
Okay, standard pneumonia picture.
Now contrast that with someone who also has difficulty breathing, but it's due to fractured ribs. Still a respiratory issue, but your critical thinking shifts focus.
Different cause, different considerations.
Exactly. Now you're thinking more about the mechanics of breathing, managing pain effectively so they can breathe deeper, checking how much their chest moves, different pain relief options specific to that injury. An experienced nurse might blend these elements almost unconsciously, but the model helps break it down.
Let's make it even more concrete. The book introduces a scenario with a patient named Mr. Lawson.
Ah, yes, Mr. Lawson. Good example.
So he's 68, had abdominal surgery the day before. His nurse, Tanya, goes in and finds him lying flat, looking tense, arms kind of guarding his abdomen.
Yeah, red flags right there. Flat on back after abdominal surgery. Usually not ideal. The tenseness, the guarding.
So Tanya starts her assessment. What's her critical thinking process look like?
Okay, so she sees the position. First thought, comfort, wound pressure. She checks his surgical wound looks okay. She gently palpates his abdomen. He winces. That's pain. She asks about turning. He hasn't turned since last night. Why? Points to the incision. Pain level, a 7 out of 10. Ouch.
High pain level hasn't moved, connecting the dots.
Exactly. She quickly checks his chart electronic health record, sees he's overdue for his pain medication. So she's assessed, she's analyzing the data. Pain is preventing mobility. Priority problems jump out. Pain, risk related to immobility.
Makes sense. So what does she do?
Immediate actions. Gets that analgesic administered. Then she gets help from the assistive personnel, the AP, to carefully reposition him. She's not just reacting, she's interpreting the whole picture. She knows he has a right to pain control, and she's also thinking ahead.
About the risks.
Yeah, the risks of him staying immobile, blood clots, DVT, pneumonia, things you really want to prevent after surgery. Early mobility is key, but pain was the barrier. She addressed the barrier first.
That systematic approach is really clear there. It's not just one thing, it's connecting all those pieces.
And that leads right into the core skills needed for critical thinking. It's more than just knowing facts, it's how you use them.
It's like constantly asking why.
Yeah.
Right.
Absolutely. The book outlines several key skills. Interpretation, basically being organized when you gather information, spotting patterns, clarifying anything fuzzy.
Okay, getting the data straight.
Then analysis. Looking at the data with an open mind, avoiding assumptions. Does this info really show a problem, or is it something else?
Challenging your own first impressions.
Exactly. Inference is about finding the meaning, the connections between different findings. What does it all add up to? And self-regulation, looking back at what you did, how it turned out, and figuring out how you could do better next time. Crucial for growth.
So that internal dialogue is always running. Why this condition? Are these signs expected? What else do I need?
Constantly. And this whole process fits within the framework nurses use every day. The nursing process.
The nursing process.
Yeah.
Assessment, diagnosis.
Right. The American Nurses Association defines it. It usually involves assessment, diagnosis, that's the nursing diagnosis, describing the patient's response, then outcome identification and planning, implementation, and finally evaluation. Some models combine planning and outcome ID.
It's that cyclical flow you mentioned. Assess, plan, do, check, adjust.
Precisely. And the NCSBN also highlights 6 cognitive skills that fit right in: recognizing cues, analyzing them, prioritizing problems, generating solutions, taking action, and evaluating outcomes. Very similar concepts, different ways of framing it.
So how does general problem solving fit in? Like the example you gave earlier, the home care patient.
That's a great example of practical problem solving. The nurse identifies the specific problem, patient can't read the labels, so isn't taking meds right, collects data, observes the difficulty, implements a solution, bigger labels, pill organizer. It's targeted.
Makes sense. What about intuition, that gut feeling?
Intuition. It's interesting. Experienced nurses often develop a sense when something's off, a red flag. It can trigger investigation. But, and this is important, it must be backed up by reasoning and evidence. It's not reliable on its own, especially for newer nurses who haven't built that deep experience base yet. You can't just go on a hunch.
Good point. Needs to be paired with solid thinking. Now, let's circle back to Mr. Lawson. After Tanya gave him pain meds, what's next in terms of thinking?
Okay, so let's say Tanya comes back later. Mr. Lawson got pain relief, maybe moved a bit, but now suppose he's restless, short of breath. And he says, I have this terrible new pain in my chest.
Uh-oh. Different symptoms.
Big difference. This is where diagnostic reasoning kicks in hard. It's about understanding the clinical problem by gathering and analyzing these new clues. An expert nurse sees this pattern. Recent surgery, immobility, now sudden restlessness, shortness of breath, chest pain, maybe changes in vital signs.
The alarm bells are ringing.
Loudly. The nurse might quickly suspect something serious, like a pulmonary embolus, a blood clot in the lung. This clinical judgment leads to forming a relevant nursing diagnosis, like impaired gas exchange or maybe acute pain related to a different cause now.
And you stressed nursing diagnosis there.
Crucially, yes. Nurses don't make the medical diagnosis of pulmonary embolus. That's the physician's or provider's role. But our assessment, our diagnostic reasoning, our nursing diagnoses guide our immediate actions, like getting oxygen on, raising the head of the bed, monitoring vitals closely, and urgently notifying the medical team with specific data.
So you identify the patient's response and the potential medical issue brewing.
Exactly. And if you're ever uncertain, keep gathering data. Don't jump to conclusions without enough evidence.
This leads naturally into clinical decision-making then, right? Deciding what to do.
Precisely. Clinical decision-making is focused on resolving the patient problems you've identified. Let's say you have a different patient, maybe someone less mobile, and you notice persistent redness over their hip that doesn't fade.
Potential pressure injury.
Right. You identify the problem, maybe impaired skin integrity. Your clinical decision-making then involves choosing the best nursing interventions based on evidence. Specific skincare, perhaps ordering a special mattress, implementing a strict turning schedule.
And a really important part of making good decisions is actually knowing the patient, isn't it? Not just their chart.
Oh, absolutely critical. Knowing the patient goes beyond the diagnosis. It's understanding their usual patterns, how they typically respond to things, what their baseline is, what they value, knowing them as a person.
How do you develop that? Seems like it takes time.
It does. The book suggests practical things. Spend focused time during your assessments, really listen to their experiences, know their typical behaviors and schedules, check on them consistently, not just when something's wrong, ask for continuity in assignments if possible, and just talk to them, engage in real conversation.
That deeper knowledge must make decisions quicker, more accurate.
Definitely. Especially for experienced nurses. It helps you spot subtle deviations from their norm much faster. And in nursing, things change fast. You often have multiple problems demanding attention.
Prioritization. Huge challenge.
Huge. You have to constantly weigh things. The patient's immediate condition is number one, obviously, but you also consider risks versus benefits of options, basic needs, think Maslow's hierarchy, breathing before belonging, the danger of delaying treatment, and practical things like time, staffing, what you can delegate.
So if a patient suddenly tanks their blood pressure and is barely responsive,
that takes priority over everything else. Getting a routine urine sample can wait. You stabilize the critical patient first. That's clinical decision-making under pressure.
it's clear this kind of thinking isn't something you just have. It develops over time. The book talks about levels.
Yes, it does. Think of it as a progression. Level 1 is basic critical thinking. This is typical for nursing students or new grads. Thinking is often concrete, very task-oriented, relies heavily on rules and procedures from the book or experts.
Like following the steps for an IV dressing change exactly as written, maybe not adapting if the patient's skin is fragile.
Exactly. You follow the recipe. Then you move to complex critical thinking. Here, you start to separate your thinking from the experts a bit more. You analyze choices independently, you're more creative, you adapt or modify approaches based on the specific patient situation.
Like the example of adapting how you teach inhaler use for someone with weak hands.
Perfect example. You're not just repeating the standard steps, you're tailoring it. Let's jump back to Mr. Lawson, the scenario where he suddenly develops chest pain and shortness of breath.
Okay, the suspected PE situation.
Right. Tanya, operating at a complex level here, doesn't just assume is his surgical pain getting worse. She thinks outside that box. She asks specifically, is this pain different? He says yes, sharp, in his chest. She rechecks vitals, sees the heart rate jump, become irregular.
Connecting new dots.
She recognizes these aren't typical post-op incision pain signs. This pattern suggests something more serious, potentially life-threatening. Her complex thinking leads her to call the physician immediately with specific concerning data. That's moving beyond basic rule following.
And the final level.
Commitment. At this level, you anticipate the need to make choices without help, you assess the pros and cons, make a decision, and you stand by it, taking full accountability. You're confident in your reasoning.
That journey makes sense. So we've talked competencies, levels. What about those other core components from the model? Knowledge, experience?
Right, let's revisit those. Your knowledge base is foundational. It comes from your education, sure, but also ongoing learning, reading journals, attending conferences, getting certifications, and it has to be holistic, physical, psychological, social, ethical, cultural dimensions.
All interconnected.
But the most critical knowledge source, it's always the patient data. Your observations, your assessment findings, what they tell you, the chart, lab results. If you have a patient with diabetes, your knowledge base tells you to pay close attention to their feet, their wound healing, their blood sugar trends, because you anticipate potential issues in those areas.
Knowledge directs your focus.
Exactly. And then there's experience. Nursing is learned by doing. Clinicals, preceptorships, your first job. Every patient encounter builds your experience. You learn from observing, touching, talking, reflecting.
Learning from mistakes, too, presumably.
Absolutely. A safe environment where you can debrief and learn is crucial. Experience builds your internal library of cases. You start recognizing patterns faster because you've seen something similar before. You learn how to adapt skills safely.
And the environment itself plays a role.
Hugely. Think about it. High-stress ICU versus a calmer clinic setting. Time pressure. Interruptions. Oh, the interruptions. Task complexity. These all impact your ability to think clearly.
I bet. It's hard to think straight when alarms are ringing and people are demanding things.
It really is, and timeliness is critical. Remember that study about cardiac arrests? Signs were often there hours before but not acted on. So, practical tips. Get help when you're overloaded, know your limits, collaborate, prioritize like mad, find good role models.
That brings us to the personal side, the attitudes of a critical thinker. It's not just about skills, it's a mindset.
Absolutely. It's how you approach problems. Let's think about Tanya again. When Mr. Lawson is anxious and short of breath before the medical team arrives, she's showing curiosity, wanting to understand why he's suddenly worse. And discipline, she doesn't just reassure him vaguely. She asks specific questions, reassesses him thoroughly to get more data.
So specific attitudes drive specific actions.
Definitely. Think about confidence. Believing in your ability allows you to focus on the patient, not your own anxiety. It builds trust. But it also means knowing when not to do something if you aren't confident or competent.
Good point. Safety first.
Always. Then there's thinking independently. Not just accepting tradition, but looking for evidence. Fairness, avoiding personal biases. Responsibility and accountability, owning your actions. No shortcuts, especially with things like meds.
Perseverance.
Huge. Not giving up easily. If a patient can't communicate one way, you keep trying other ways until you find what works. Like Tanya sticking with Mr. Lawson's assessment even when it was getting tense.
Humility seems important too.
Oh, very. Humility and self-awareness. Knowing what you don't know, being willing to ask for help, recognizing your own biases. It's not weakness, it's strength.
And when the medical team finally gets to Mr. Lawson, Tanya shows that independence and discipline by having her data ready, reporting objectively. She has integrity.
Exactly. She knows her scope, provides the vital nursing perspective, which leads us to the standards for critical thinking.
Two types.
Right.
Intellectual and professional.
Correct. Intellectual standards are like universal rules for good thinking. Things like being clear, precise, accurate, relevant, logical. When Tanya asks about the bleeding risk of anticoagulants with Mr. Lawson's fresh wound, that's relevant. When she asks if she can give more pain meds so he can tolerate the x-ray, that's logical.
Applying those standards to the situation.
Yes, and professional standards are about the nursing context. Ethical criteria, always considering patient values. Evidence-based criteria using research and established guidelines like from AACN or ONS. And professional responsibility, following your Nurse Practice Act, ANA standards, hospital policies. These ensure high-quality, safe, ethical care.
So you make the decision, you act, but it doesn't end there. Evaluation is key.
Absolutely. Evaluation is part of the nursing process loop. Did the interventions work? Were the outcomes met? But it's also about self-evaluation.
Yeah.
And reflection is a powerful tool for that.
The instant replay idea.
Exactly. Purposefully thinking back on a situation. What happened? How did I respond? What were my thoughts and feelings? What did I learn? How could I do it differently? It's how you grow.
Is that where journaling comes in?
It can be very helpful. A reflective journal, kept private, lets you process experiences. Ask yourself those tough questions. Did I act appropriately? Was I relying on tradition or evidence? What could I have done better?
And talking it through with others.
Invaluable. Meeting with colleagues, discussing cases, getting feedback, participating in debriefs or safety huddles after critical incidents. It validates your thinking, you learn from others, and it helps prevent future issues.
One more tool mentioned is concept mapping.
Ah, yes. Concept maps are visual diagrams. You put the patient's problems down and draw lines to connect them to interventions, assessment data, showing the relationships. It helps you see the whole picture, organize complex information, and really strengthens your critical thinking by making you link everything together.
So pulling it all together, it seems like critical thinking and the nursing process aren't separate things at all.
Not at all. They're completely interdependent. You can't really have effective nursing practice without both working together constantly. Your ability to think critically fuels the nursing process, and the nursing process provides the structure for applying that thinking to make sound clinical judgments.
So the key takeaways are really understanding those components: knowledge, experience, attitudes, standards, and committing to that continuous cycle of doing, evaluating, reflecting, and improving.
That's the essence of it. It's a lifelong journey of learning and refinement.
And for everyone listening, especially students prepping for exams or new grads, starting out mastering these concepts isn't just academic. It's fundamental for the NCLEX, yes. But way more importantly, it's the absolute foundation for providing safe, effective, compassionate care.
Couldn't agree more. This is the heart of professional nursing.
So, as we finish up this deep dive, here's something to think about. in this incredibly dynamic field of nursing, how will your personal commitment to keep questioning, keep learning, keep reflecting, how will that elevate the care you provide and ultimately shape the well-being of your future patients?
A really important question to carry forward.
Definitely something to mull over. Thank you so much for joining us today as we explored critical thinking and clinical judgment. We really appreciate you being part of the Deep Dive Learning community.
Yes, thank you for tuning in. Keep learning, keep thinking critically. Your skills make a huge difference. It's vital work you're preparing for or already doing.